Okay, then. Thank you, Dean Lewis, for that nice introduction and for educating all of us about this endowed lectureship in diabetes. I'm really very honored to be here, and I think it's a wonderful gift of a mother to endow such a lectureship for her children. But isn't it sad that these children had to live a long life complicated by diabetes that ended in their early death? And so I think that this lecture is a wonderful platform for public awareness of the problem of diabetes, and that it's a global epidemic. And you can see from this slide that approximately 382 million people worldwide have this disease, and it's expected to grow to 438 million over the next 20 years. Diabetes alone accounts for 4 million deaths per year at a worldwide cost of $376 billion. And this slide is a geographical depiction of the prevalence of diabetes in the world. And you could see that estimated 382 million people worldwide with the disease and where they live. And note that the highest prevalence is in the Western Pacific Asian countries. But also what's most troubling about this slide is that 46% of the people worldwide with diabetes don't know that they have it. And they increase the morbidity and premature mortality that is such a heavy, costly burden, both personally and economically. And so China leads the world in the number of people with diabetes, followed by India, and unfortunately, the great United States of America ranks number 3 in the prevalence of diabetes. And you can see this is due to the dramatic increase from 1980 to 2011 in cases of diabetes, such that currently 26 million people in this country have this disease, 8.3% of the entire population, of whom 7 million do not know they have the disease. And this is important for all of you in clinical practice, that you understand the importance of screening for this disease, so that you can perhaps intervene with early treatment and prevent the devastating complications and premature mortality that's associated with the disease. And in 2011, it was noted from epidemiological studies that the greatest burden in our population is the older adult population that has a 13 times greater prevalence compared to a younger cohort at 45 years of age. And with the aging population, both in the United States and worldwide, this is going to contribute to the increasing numbers of people with this disease. However, we need to be aware of, as we take care of people across the trajectory of life, that there's youth in this country with diabetes, both type 1 diabetes, like Mrs. Nelson's children, and those with type 2 diabetes. And that number is going to increase as well as they age, and as obesity and sedentary lifestyle in this country continues to challenge us. Again, an important piece of information for you in clinical practice is, again, that's about 79 million people in this country have prediabetes. That is, they have glucose intolerance. And if they don't have early intervention, particularly of lifestyle modification, or if they have metabolic parameters which are indicative of medication therapy, then they will go on to get type 2 diabetes. And prevention is so important because once you have type 2 diabetes, you have it. It's not cured, it doesn't go away, and the complications ensue at a different rate. And in the United States, $174 billion is spent on this disease. And if you think about the United States as one country, that number is embedded in that worldwide $376 billion. So there's a lot of diabetes in this country and a lot of diabetes-related costs associated with it. And in fact, for Medicare, total Medicare expenditures, diabetes and diabetes-related complications accounts for 40%. 40% of all Medicare expenditures. So what is this disease? Whoops. So diabetes is a group of metabolic diseases characterized by hyperglycemia or high blood sugar that is due to defects in insulin secretion, insulin action, or both. And it is the physiological defects that define type 1 diabetes or type 2 diabetes and differentiate one from another, such that people with type 1 diabetes have a defect in insulin secretion and insulin production. And people with type 2 diabetes have a physiological defect in insulin production, insulin secretion, and insulin action at the cellular level. There was a time when we did not know enough about type 1 and type 2 diabetes, such that it was called juvenile onset diabetes or adult onset diabetes. For those of you who might be interested in nursing history, if you look back at the diabetes literature, you'll see that nomenclature used. And it was really because the majority of people who were young got type 1 diabetes. So in those older textbooks, you'll see that anyone who was less than 30 years of age got juvenile diabetes, and anyone who was 40 years of age or older got adult diabetes. And I don't really know what we call people between 30 and 40 in terms of their diabetes, but it is really the pathophysiological defects. And so when you're looking at people clinically and you're diagnosing them, you want to really look at the metabolic parameters and their insulin levels, et cetera, to really decide and discern whether they have type 1 or type 2 diabetes. The other interesting thing that happens clinically for the clinical people in the audience is that very often patients may not know what type of diabetes they have, and you have to use these lab assays as your indices for helping to determine what type of diabetes they have. But we all know that there's serious complications related to diabetes, and it's due to the chronic hyperglycemia, the chronic high blood sugar over many years, that's associated with the long-term complications, both microvascular and macrovascular. The characteristics of type 2 diabetes are most common in that family history is the most common predisposing factor for people having type 2 diabetes. You see it in families and in ethnic minorities, especially so. They have high incidence and prevalence, and there's a high familial component. Obesity or a history of obesity is another common predisposing factor, and it's driven by the sedentary lifestyles in this country. I mean, it's really remarkable when you think about statistics, and you could tell I like to frame my talks that way because it really drives home the point. Currently in the United States of America, 78 million individuals are obese. And on average, that's about 35 pounds overweight. And so you could see then the connection between those rates of obesity to why the problem of diabetes is going to continue. And it's a disease that frequently goes undiagnosed for years. You saw that both in the global slide where I noted that 46% globally of the people with the disease are undiagnosed, in the United States 7 million. So people present to us in the clinical setting with complications, and then at the same time we're informing them that they have this chronic disease and may have had it for quite a while. And again, it's a disease that typically occurs in adulthood, but we're seeing type 2 diabetes occur more and more in youth. Coronary heart disease is the leading cause of death worldwide, and that's true of people affected by diabetes. Diabetes is also the leading cause of end-stage renal disease, and it also accounts for about 170 million cases of diabetic retinopathy that impairs vision. So there's a lot of disability associated with complications such as this. And also, diabetes unfortunately accounts for 1 million annual limb amputations. That's one every 30 seconds worldwide. And we all know as nurses that that's preventable with patient education and screening of feet. Often socks and shoes don't come off in clinical practice, especially in outpatient offices. So all of you outpatient nurses and nurse practitioners, remember to remove the shoes and socks of those patients with diabetes. So is there any good news about this? And yes, there is. We have important evidence that was the result of very big trials, multi-center trials, and one of them was the Diabetes Control and Complications trial, in which approximately 3,000 individuals aged 13 to 39 years of age participated. And what was found was that intensive insulin therapy compared to more conventional, and conventional was 2 shots a day, 1 or 2 shots a day of insulin, compared to multiple insulin injections, 3 to 4, or an insulin pump, that when that intensive therapy resulted in lowered blood glucose to a normal level, and the normal level being 7% hemoglobin A1C or less, that there was dramatic decreases in diabetes-related complications. So there is evidence to share with patients about the importance of controlling blood glucose. Very early in my practice, I didn't have this evidence. The only evidence that was available was some work that was done with women who were pregnant. And we could tell them that if they controlled their blood sugar to a near normal range, that they would have good birth outcomes. But that's all that I could tell the patients at that time early in my career. But now we have important evidence that we can share with patients about why should I do this, it's so hard to do, and what difference will it make anyway. Well, it'll make a lot of difference, because if they have intensive therapy that lowers their blood glucose to normal range, they'll get 15 years on average of complication-free living and 5 more years of life expectancy. Another important, very big trial, multi-site trial, that involved 3,000 or so individuals in this country. They were enrolled due to being overweight or obese and having prediabetes or this glucose intolerance, was the Diabetes Prevention Program. And these participants were randomly assigned to one of these 3 types of interventions. One was intensive lifestyle intervention, which was all focused on exercise with coaching and classes and dietary modification. And then another arm was metformin, which is an insulin sensitizer. You know, this drug sensitizes the receptors on the cell to pick up insulin. And then a placebo arm. And that randomization took place after everybody got the standard what to do about diet and physical activity. And all you need to see here is that on the lower line, which is the light blue, indicates the lifestyle intervention. And this trial, as big as it was, and as many participants, was a trial that ended early. And that's always great for researchers who are addressing a very important, complex problem. Because it ended early, there was noted that there was already a 58% reduction in the incidence of individuals with prediabetes going on to get type 2 diabetes. This trial is also the trial that gave us that 150 minutes of exercise per week as a baseline standard for improving weight loss or trying to achieve weight loss. So now I'm going to segue a little bit into the area that I focus on, and that's diabetes in ethnic minorities, and my program of research is built on that and focuses on that. And you can see in this slide that ethnic minorities are disproportionately affected by diabetes, and particularly black women, which is the highest line there, the black line. And they are a group that my work focused on. And at the time that health disparities, and especially related to diabetes, was emerging, that it was a particular problem for ethnic minorities, there wasn't a lot in the literature on this, and particularly not focused on women. So I decided to go in that direction. And in terms of women, the prevalence of diabetes for women 40 to 50 years of age doubles. But for black women, it's very high. 33% of all black women in this age group have type 2 diabetes. And they suffer from complications at a more severe extent than any other group of people, and have a 40% greater mortality compared to black men and white men and women. So the program of research started with myself and colleagues, and student Nancy Millay was a student who was involved in this work, in describing the problem qualitatively. We brought a group of women together from the greater New Haven area. This work took place when I was at Yale University. And we wanted to hear from them what was happening in the context of diabetes for themselves and with their healthcare provider. These women, to give you a background, were utilizers of primary care. We asked people to enroll that they have a usual source of primary care. These were on average midlife women who were working, had ability to pay for insurance, and were fairly well educated. So they were a self-select group of volunteers who were willing to share with us their perceptions of what was going on. And they let us know that there was a great need for diabetes education, that it was something that they weren't getting in the context of care. Important traditional, cultural aspects of their care were not addressed. They didn't see their faces in any of the pharmaceutical information or any of the clinical setting information. They wanted not to be exclusively paid attention to, but they wanted inclusion. They also felt that there was a greater need for care-provider rapport so that it was bidirectional and not unidirectional, because these women also struggled with weight. On average, the most of them were obese, and they were always getting the message that it was their job to lose weight and improve their diabetes outcomes. And then the importance of family support, which is very important to the Black community, was never noted. It was always this singular interaction with the provider. So then we thought, well, it was important now that we had that information to find out quantitatively what was going on by using some survey instruments. And in, again, a small group of women, we were really quite discouraged to see this data because, again, they were like what the literature said, and if you remember the earlier slide, that this is a group 33% of whom between 40 and 50 have the highest rates of diabetes. And here we see it on average that they were 48 years of age, they were overweight by BMI and weight in pounds. They were utilizers of primary care, they were working, the majority of them were in partnered relationships. But if you look at the hemoglobin A1C values in red, and you know that the norm is less than 7, look at the range and look at the average. They had very poor metabolic control based on hemoglobin A1C, and given that, yet only 68% of them were on medications. So this is health disparities right there on that slide, what's going on. So then we wanted to see, well, what's happening in primary care for them in terms of cancer screening. So we were happy to see that almost 90% of the time they were having mammography and pap smear screening, and colon cancer screening when age appropriate. But look at the diabetes complication screening. Less than 50% of the time. So again, health disparities for this group of women. So I don't have slides to show you, but it's important for me to let you know so that you get the full picture. Part of my program of research then went on to assess primary care providers' practice patterns related to diabetes. And that led to the development of the diabetes care concentration for advanced practice nurses. Because with this data, from the patient's perspectives and their responses, because it's self-report, we then went to the clinical setting and got an idea of what the providers were doing by speaking to them, but more importantly, validating with chart audits and actual documentation to find that there was deficient knowledge and practice patterns of the care providers. So then we kind of got a picture for why the patients also were having poor clinical care provided to them. But getting back to this program of research, we took the qualitative and the quantitative information that the women provided us. And then with that, they informed the development of an intervention that was more culturally relevant. It was a group intervention of behavioral self-management and nurse practitioner care in primary care. And the outcomes were really about the process and feasibility of being able to do that. Would the women come to the intervention? Would they attend it? Would it be acceptable? Would the providers be part of the intervention in the way that it was conceptualized and manualized by protocol, as well as look at some preliminary effects of outcomes on the metabolic and psychosocial outcomes? And this can tell you how the science was early then, because I used a one-group pre-test, post-test design and got this funded, and this would be a more difficult endeavor nowadays. But one of the things that we always did in our program of research, and I continue to do, is to involve graduate students, advanced practice nurses, and doctoral students so that we can use the environment in which we're doing our research as a laboratory, both for clinical practice and research practice development. So these women, again, we recruited from the greater New Haven area. They looked very much like the women who informed the intervention. We got to see it again, that they had, poor metabolic control despite being utilizers of the primary care system. We measured diabetes self-efficacy on a scale to 100, and you could see that the women had pretty high self-efficacy, which is never a surprise when people self-select or volunteer for a research study. You're getting the most motivated individuals who feel that they have the confidence or the wherewithal to participate and hang in with this intervention that is of interest to them. But the other thing that we measured was diabetes-related emotional distress, and you can see on a scale to 100 that they had high levels of diabetes-related emotional distress. They were struggling with managing their diabetes, was causing them distress, and perhaps that too motivated them for participation. So after we followed them and they were part of the intervention, we saw that there was dramatic decreases in fasting blood glucose at 3 months and 6 months, which was very exciting for us. And hemoglobin A1C also improved at 3 months and was maintained at 6 months. In terms of the psychosocial outcomes, this was just a trend to significance at 0.06. We were very excited about it and encouraged about it because we saw that with the group process where they were getting educated, provided the opportunities to learn about their diabetes in a meaningful way, get the skills to apply for self-management, work it out with other women in the group with them, have nurse practitioner care that would reinforce what they were learning in the group sessions in the context of care, that their self-efficacy increased, and while their self-efficacy increased, their diabetes-related emotional distress decreased. So we were very excited about this finding. We went on then to do a pilot efficacy test of this, comparing then our intervention to a control intervention. And the control intervention was a traditional hospital or community setting-based didactic diabetes education program from A to Z. We tried to control for the time, and both groups got the monthly nurse practitioner visits as well. And because we had this diabetes concentration for advanced practice nurses, we were able to utilize our nurse practitioners in the clinic as interventionists as well as in the group sessions. Of course, being trained so that we could ensure the fidelity that the patients were getting the intervention as they should. And so again, we were very excited to see that there was a significant difference between the control group and our experimental intervention, and that the experimental intervention had reductions in hemoglobin A1C. So we moved this along then to do this testing in other groups because we wanted to see, well, will this apply to other groups if it was replicated, and would it hold up, and would they benefit more importantly? So with some of our mentees, it was tried in a family neighborhood health center that was a federally qualified center with Latino men and women, and we were excited to know that the men felt that the intervention was important to them and that they benefited from it, and the attendance was very good. And in this study, although I don't have the graphs or charts of the outcome data, the men actually did better than the women in terms of metabolic control. And then we also tested it in a group of white older adults who had asymptomatic myocardial ischemia, who were part of a larger study. And they did really well, these older adults. And in fact, so much so that when we ended the study, they wanted to meet as a group and formed their own support group. Which, again, tells us that people need this and they want it. But how can we give that to them when it's not a usual, customary part of the care that we provide in the settings that we practice in. So we went on to get funding to now test effectiveness. So those of you here who are in PhD programs, if there are any of you here or young researchers, you see how we went to describe the problem qualitatively, quantitatively, did feasibility testing, did efficacy testing. Now we're to the effectiveness trial. All in an ideal, internally controlled, internal validity kind of way, which is a whole nother conversation, but sometimes then when it's translated to practice, it doesn't hold up for a whole bunch of reasons. But in this trial, what we did, because we knew the importance of the psychosocial dimension, particularly around diabetes-related distress, was that we added a 5-week coping skills training piece to this. And Margaret A, who was the speaker last year, was a co-investigator on my study, and we actually leveraged the work in coping skills training with youth that we had developed for her study to now adults. And coping skills training, just as a modality, is derived from social learning theory, but coping skills training was first used in substance abuse and then weight loss interventions, and now we were applying it to chronic illness. And getting back to experimental design and ensuring internal validity, we had to control for attention. We couldn't give our experimental group all the bells and whistles and not the control group. We had to control for attention effect. And so they got the traditional group diabetes education program, the same as the previous pilot work, but then we gave them the additional weeks of an open question and answer period when the experimental group was getting the coping skills training. And both groups got their diabetes primary care visits. The first one was at the beginning of the study and then quarterly for 12 months. So it was an active intervention study for 1 year, and then we followed them out 2 years. Again, we recruited the same type of women. One of the things that we paid a lot of attention to, both from listening to the women as they informed intervention development along the way, gave us feedback from the pilot work, as well as reading in the literature, that we had to decrease barriers to participation. Patients want to see us. They have needs for which they want to see us in primary care in particular. But sometimes when you are a woman and you're doing multi-generational family care and you're working and life is complex, you just can't get to clinic when it's only open 8:30 to 4:30. So we made sure that we offered different times of day, evening, Saturdays. We gave them parking and travel monies for their time, child care when they were in sessions, educational materials, and blood glucose monitoring materials. And we did that instead of cash incentives for participating. We drew a lot of physiological and psychosocial measures. And the complexity of our intervention is really anchored in this trans-theoretical model of behavior change. We wanted every part of our methodology to hang on this theory, which is important, the variables of interest, etc. But it does make these interventions large and complex and in some ways burdensome when you think of the target population and them filling out all of these questionnaires. So at baseline, this is just to show you that for the most part, the women were equivalent, whether they were randomly assigned to the control group or the experimental intervention. There was really no significant difference. They were alike, except for, you'll see here in this slide, that the experimental group experienced more somatic anxiety. We had attrition. All behavioral, longitudinal research studies have attrition. And usually for behavioral interventions that are a year or more, it's about 35 to 50% attrition. So from our 109 participants, we went to 77. This analysis is an intention to treat analysis. And what that means is that everybody is included in this analysis, whether they completed it or not. And there's ways to impute data and have this done. But I want you to see what's important here. So, not to be hung up on the analysis so much as to get the message that both groups benefited. Over time, both groups improved their hemoglobin A1C. And if you can see here, from baseline to 3 months was when they were in group sessions, and they had the most dramatic decreases. And then they kind of bounced around both groups, whether they were the control or the intervention. And then active intervention ended at a year, and now there's recidivism back to baseline, particularly in the control group. Now, this is a slide that shows you the characteristics of those who completed the study compared to those who did not complete, or the non-completers. And what you can see here, and what we were really surprised and maybe naive to see, and admit to being naive about it, was that there was significant differences in the socio-demographic characteristics of those people who could not complete the study to those who completed the study. And most especially, you can see that as well in the quality of life measure and in somatic anxiety. So there was a lot of reason for attrition in this group of participants. But we had confidence in our intention to treat analysis, because when we just looked at the completers, it's almost a mirror image. Again, if you see that from baseline to 3 months, they came down dramatically, bounced around from 3 to 6, 12 months, and then at 24 months, they're going back up. But both groups had significant changes from baseline over the time period that they were followed. Now, emotional distress was that thing that we're really interested in, and especially because we added the coping skills training component, and we saw that in the intervention group at 24 months, that they had significant improvement compared to the control group. If you look at 9 months, you see that they went up higher, and we're just making some assumptions about what it means to be an active intervention, separated from that, now applying the things that you've learned in the context of diabetes self-management in life to reframe a lot of the way you're thinking about your disease and putting yourself forward, and maybe that's why they were struggling and had a bump up. So what did we learn from this? And this is very important for you in clinical practice, is that the traditional customary diabetes education that for the most part, I'm here to say, is not didactic anymore, even if it's that traditional program that's hospital or community-based, because there's such a skills component to diabetes care now, with individuals doing blood glucose monitoring, understanding about measuring food and looking at nutrient labels, etc., examining their feet, that it is behavior oriented. It's just not didactic. They're just not passive recipients of the information. So that even referring individuals to that kind of program is beneficial, because for the most part, people in primary care are not afforded or referred to these types of programs, and when they do, we saw that they benefited just as much as the women in the experimental intervention. And you know, Medicare set the reimbursement regulations for now all third-party payers paying for diabetes education. 10 hours at initial diagnosis and 4 hours every year thereafter, as the provider substantiates the need, and as providers we could always substantiate the need for more diabetes education and support. When there's high levels of emotional distress, somatic anxiety, low quality of life, that these individuals, and most individuals, as they manage chronic illness across the trajectory, as life is ever-changing, need psychosocial and behavioral support, such as the coping skills training that we gave them. And in doing that, that's the only way that we're going to maintain and sustain improvements in the health outcomes that we're most concerned with, that will prevent complications and premature mortality. The other thing that's important for us as we look to our program of research, and we thought about this more, is that these self-management interventions in primary care and real-world settings need to consider a minimal dose or a short amount of time. They cannot be as extensive as our theoretically driven intervention that we were so proud to say included all of the variables in the cognitive, affective, psychosocial domain, and we need to consider what can we give to patients that they could benefit from, and that we as providers have the resources to give them in the context of care. So in thinking about that, we've moved our program of research to another platform, and that's a virtual life platform. And so our current project is Diabetes Live, Learning in a Virtual Environment. And that's because we wanted to eliminate the barriers to participation with a geographical getting there, as well as this very burdensome, complex, many sessions being present at kind of intervention. We wanted to also accommodate different health literacy levels and provide a sustainable, cost-effective behavioral education and support intervention. So this is an avatar-based program. We did an R21. This is in conjunction with my colleagues at Duke University in the School of Nursing. The R21 was very feasible and showed preliminary efficacy. It was done with the Second Life virtual platform. Our platform now is being modified. The computer software specialists are currently working at it, so I have nothing to show you that could be in motion. It will have a live interactive classroom with diabetes educators who will meet at various times based on the participant needs, so that our interventionists could sit in their living room in their pajamas, as the participants might as well on the other end, and it'll be synchronous and everyone can participate. We will also have all the things that a community has, such as a grocery store with interactive items. People will be able to read the nutrition facts and get feedback on every grocery item. And when they get the feedback, they'll be offered different options that are perhaps a healthier option for them in terms of snacks or other meals. We're going to do the same in the restaurants. There'll be different kinds of chains and fast food restaurant menus, and then they'll have a menu feedback mechanism so that they can then see options. And I don't know about anybody here, but whenever you're trying to diet or think about being healthier, eating clean, everything goes well when you're home until now you're going to go with your friends and family to a restaurant and you say, oh no. And so this is a very interesting way to have individuals learn how to choose from a menu in a wiser way. We'll also have in there a pharmacy where people can get information about the medications they're on, and also links for them to buy items that are more cost beneficial online. We will also have a gym, an outside Zen garden, because in our first virtual life environment, we did some geo-mapping of where the participants spent their time in the virtual community, and it was built on an island, and around the island was water. And when we looked at the participant flow in this virtual life environment, we saw all these dots along the edges, and they liked to be near the water for relaxation. And so we now created in this virtual life environment a Zen garden with water and music, and so that they can do stress and meditation there. There's a bookstore, there's a community center where they could meet, a gym, etc. So we're hoping that this will be something that's even more extensive. We're looking at social support in a bigger way in this study. We're recruiting 150 participants from the greater New York City 5 boroughs, and then 150 from the Raleigh-Durham area, so that it's going to help us see if we could extend this kind of web-based virtual life platform across geography from urban and more suburban rural settings. So what do we know about diabetes in general after all of this that I told you today? Is that diabetes is increasing in epidemic proportion. And in fact, it has been called by the World Health Organization and the International Diabetes Federation the tsunami of chronic illnesses. And I think that you would agree it is, in fact, indeed, and it's going to continue to grow as the population ages and we continue to be more sedentary. Less than 50% of individuals with diabetes ever receive education and behavioral support. So when you think about our patients, they do pretty well, considering that they've never been afforded the opportunity to learn how to self-manage their disease in a meaningful way. We do know that behavioral interventions are effective but not sustainable, and we have to think about new modalities of intervention that are time efficient and cost efficient as well as effective. And we're hoping that we can do that with our virtual life intervention. But importantly, we need policy that legislates based on our scientific evidence that ongoing educational and behavioral support is needed for people with chronic disease. Everybody with chronic disease can go quarterly for their medical visit. They could have their blood pressure checked, their weight taken, have laboratory measures drawn, prescriptions written, a little chit-chat for however long the visit is. That gets reimbursed. But a behavioral intervention like coping skills training or counseling or coaching or some other kind of support is not reimbursed. And we need legislation to do that. And so I'm very honored again and excited to have been the speaker today, because I think that, again, this lecture provides an opportunity to educate others about the importance of addressing and preventing diabetes in a larger way in the United States and across the globe, and that it is a platform, this lecture, for public awareness. And I thank you very much for your attention. Thank you.
I want to thank Dr. Melkus. I think what she's shown us again is how rigorous research really informs our practice. And I think we would love to have you back when your first life is up and running. But I'm wondering, we've got some time. It's only about 2:45. Are there some questions that you might like to ask Dr. Melkus? Things from your practice or just thoughts? Yes?
When will this be implemented, the live study?
The live study?
When we have results, approximately.
Okay. It's a 5-year study that's been funded by the National Institute of Heart, Lung, and Blood. And we're just finishing the platform. We're going to start enrolling participants in June. We're going to go live with the beginning groups to do intervention in August. So it's going to be a few years, unfortunately. But there are other studies in the literature. Margaret A's on coping skills training in youth. It's called Teens Cope. There are other interventions. There's a lot in the literature about telemonitoring and phone intervention. So it's going to be a while. Sorry.
Well, when you're ready to do more multi-site, don't forget us.
I won't forget you.
Other questions?
Yes?
Are you concerned in developing the virtual world that it might contribute to the sedentary lifestyle?
Ah, that's very interesting. That's very interesting. In terms of exercise, there's interactive exercises for the group that they could participate while they're online. But that is a very good point. And we are going to measure physical activity. Of course, you would imagine that. But we're hoping that it would promote it, and that on the virtual life, they'll learn new and different things that they could do that then they could apply outside in life. And one of the important things for me as a nurse practitioner, and I've practiced always as a nurse practitioner, is that I don't really like to talk about exercise to patients, because they're thinking about some really formal program or sport, but increasing physical activity is really the goal. But you bring up a very good point.
What about your virtual literacy contributing to healthcare disparity? You mentioned that before.
Oh, that's very interesting. And that's part of why we're looking in the New York area, although in the Raleigh-Durham area there's a high percentage of Black Americans. It is a thing we struggle with, because the participants must have a computer or access to a computer, and it has to, they have to have the internet. We are going to give them the speakers, the cameras, and the Fitbits. They get that for study participation, but we are concerned about it. And our next step after this is that we're going to try to see if at least we could get it on tablet. I'm learning a lot about computer engineering. This virtual environment has too much real estate for an iPhone. So I was hoping that there was a way that even if they were somehow signed in, if the interventionist signed them in, that they could at least access somehow from their smartphone. And that is a problem for us, because we know that certain patients in the Bellevue system in New York City, that's the city hospital that's affiliated with NYU, that everybody has the phone, but not everybody has the computer. So that's a very important limitation to this study. Yes?
Is
along the same lines, I was thinking about limitations for this population here in Buffalo. And one thing I know is a lot of people don't have smartphones. I come from New York City where everyone, even if they don't have other things, has a smartphone. And here, very few people do. And particularly in certain neighborhoods, I've noticed that people don't have computers, don't have internet access. They use, their phone to get online, but it's, minimal. They have to maybe go to the library. I've noticed that people who are not students come to use our libraries on the weekends to get online.
Well, that's what we're hoping. We're hoping that people who are really interested, that we could connect them to the community centers or the library and make sure that we have synchronous sessions at the times when they would be there. But it is a problem and it's an important limitation. But we are trying to start somewhere.
I mean, it's very interesting. I'm just curious how it would translate to.
Yeah. You know what's interesting, what was really interesting in the pilot work was that the older population really loved it and participated a lot. So sometimes we have a bias thinking, oh, well, the older people aren't going to do this. They were doing it. Because the participants, you make your own avatar. You can look however you want. So.
Any other questions, thoughts? We are eager to have you join us for a reception. Dr. Melkus will be there if you have some other questions. Please join me in thanking her so much.
Thank you. It's a pleasure.
I actually would love to have you come back.